شاء الله تكون الاستفادة عامة على الجميع. آه، ف وإن شاء الله يعني تستفيدوا تستفيدوا من what I'm going to say. And في أول 5 دقايق I will just stress on the fact that why do we find it confusing. And في المحاضرة اللي فاتت واللي قبلها I said that because there's a lot of very nearby diagnoses، يعني كلهم neighbors وقرايب واكلين عيش وملح مع بعض زي ما انتم شايفين، فهم كلهم ليهم نفس الاتيتيود بالنسبه للسيمتومز والساينز، ففي اوفرلاب كبيره ما بين الديفرنت diagnoses. other points ان بيبقى في too many features، وفي ضغط الشغل وضغط الحياه والسرعه بتاعت الاداء ساعات we don't look into all these symptoms together and we try to focus on one or two من الساينز اللي في البيوبسي، and then we kind of like miss the bigger pictures لأن it depends on your attitude. If you are just one of those people who put the slides on the stage for 5 seconds, it's not going to work. Then the GI biopsies is not your cup of tea. ليه؟ لأن معناها إن you will not be giving really a consistent diagnosis every time. بصرف النظر عن الخبرة أو إنك شفتي 2000 شفتي 10000 it doesn't matter، لأن كل حالة منفصلة عن التانية وكل حاجة لها قائمة بذاتها. You have to look into all of these features when you look into a biopsy. And as I told you, sometimes the inflammatory bowel disease takes for me up to 45 minutes to sort out. This is the amount of things. والنقطة الثالثة اللي هي برضو بشوفها كتير إن هي في ناس try to stick to a very vague diagnosis. ليه؟ لأن زي ما قلت لكم قبل كده الشخص اللي هو بيبقى stuck ل vague diagnosis، سواء تسميه chronic colitis أو chronic active colitis أو مجرد acute colitis، فهو you can sleep at night. You see, this is when you put this stampa والdiagnosis عندك في الباك جراوند حطها على الديسكتوب و it looks chronic، تقومي حاطة الستامبا بتاعت الكرونيك it looks acute، هتحطي الستامبا بتاعت الاكيوت وخلاص وكان الله بالسر عليم. انا بالنسبه لي الستاندرد ريبورتس اللي هي بتبقى حطها على الديسكتوب عشان مجرد تكوبي وبيست في الحالات عشان خاطر توفري وقت ومجهود وكده. الحالة الوحيدة اللي أنا عندي ليها يعني standard report هي النورمال. You see, in normal, I have, yes, a standardized report that I tend to put it and add a little bit on it. يعني لو كان في 1 or 2 more signs that I saw in the biopsy. لكن for any abnormal one, I don't have a standard report that I will copy and paste. I will build the report according to the case. So if your habit is to copy and paste what you have on the desktop, it's not going to work that way and it will always be a problematic. وفي المحاضرتين الأولانيين اتكلمنا على أهمية الابنورمال architecture أو الكريبت distortion، وشرحنا كل واحدة من النقط دي بالتفصيل and how you will be able to identify it. لأن what I also find زي ما اتكلمنا قبل كده إن ساعات people don't understand the concept of crypt distortion properly. They see 1 or 2 branched crypts and they call it crypt architectural distortion. أو they see a little bit of loss of parallelism and they don't look into اتجاه البيوبسي، وبالتالي they overcall the angulation, the oblique alignment of the crypt, the horizontal alignment can be missed in a lot of cases, and therefore we will be slowly revisiting those في المحاضرة النهاردة وبكرة تاني، لكن we will be of course adding more things into those. وبعدين المرة اللي فاتت طبعا we ran out of time and I was just highlighting the concept of the weathered crypts. وطبعا I showed you the top half of the crypt when you get to lose it في الاسكيميا وكده. لكن what is more common that I find it difficult for people to appreciate is how the weathered crypt looks like في when you actually look at it في transverse cut بدل vertical cut. So you can see this group here, they look normal somehow, but this group here, which they are sitting next to the other group, they looks a little bit abnormal. You can see the lumen widen up will become very sharply demarcated somehow, and then the cells become compressed and atrophic, and they don't really particularly look healthy. Yani they don't have this prominent nuclei. They are preserving some of the goblet cells, which became now very prominent, but there's still less goblet cells in some of them, not all of them. Some of them are still preserving, some of them still in transit. Like this is the weathered crypts, and this is just I don't find that this how it is. People tends to look into the vertical one for vertical biopsies, and they tell you this is a weathered crypt, but a lot of people tends to miss how it looks like for transverse section. So providing that you can keep this image in your mind, you will know what weathered crypt looks like. Again, you can see there is. This is the normal crypt. You can see the lumen is completely different for weathered crypts. Will cells becomes a little bit atrophic or unhealthy in a lot of those crypts. So these are all things to define. And again, just a close up to show you the state of the cells. You can compare and contrast. This is by all means not a normal crypts, and you will not. Just don't let this image pass you, because as I told you, one of the very difficult diagnoses هي chronic ischemia. طبعا patients بيجيله bloating, can get bouts of diarrhea, altered bowel habits مع chronic ischemia و abdominal cramps وكل الكلام دوت. لكن المشكلة في البيوبسي that if you don't pay attention to another abnormalities of the crypt, which we call it the weather crypt, then you will miss the pictures completely. And you can see the cells are really scant in numbers now in this crypt, like this one here, and all the kind of like the goblet cells trying to expand in order to take the place to cover the surface area. Like in number of cells now has become reduced a lot بالنسبة للcrypt. So all of these are ischemic events. So of course it can be produced by a lot of things. But how is but mainly by ischemia, of course. But how is why did we spend a lot of time into this? Because you need to be able to يعني لو كنت هتقفي على باب البيت وتحتفلي انك انت شفتي الكونيسيتي، يبقى you must have seen ال 2 or 3 or sometimes even 1. As I told you, very frequent branching. يعني بعض authors قالوا 5 or more بالنسبة للbiopsies, لل1 fragment of biopsy. This can help you to achieve an impressions about the chronicity. لكن so we saw a biopsy like this in the seminars, in the previous seminars, and you can figure out angulation. You can figure out the crypt loss in some areas. You can figure out some dilatation, some oblique alignment, horizontal alignment, whatever. But today the focus will be more on other features that will help us ان احنا نحاول to resolve البازل will resolve المشكلة. So this is what we will be talking about today, to search for some other diagnostic clues. And I will be talking about a lot today about the inflammatory cells in the colon. وهي الفكرة، أنا أول ما يعني دايما لما بدي محاضرات كولايتس وأقول أنا هبتدي أتكلم عن inflammatory cells، الحضور معظمهم بيمشي، فاللي عايز يمشي يتفضل. ليه؟ لأنها it is هو جاي منين ده؟ هيقعد بقى يحكي لنا كمان عن inflammatory cells على الليمفوسايتس، يعني كمان ناقصه هي الحكايه ان يعني ناقصه، يعني مش ناقصينك. اوكي، كفايه اللي حصل لنا في الشغل النهارده، مش هيبقى انت والشغل علينا، ما علينا. طيب انا بس يعني I want to tell you that yes, we have this overlap. As you all know, this is historical between the infectious colitis, Crohn's disease, and the ulcerative colitis. Of course, the diffuse inflammation, which is the one factor that we tend to pay a lot of attention to, this diffuse inflammation. We love that, yes, we love that, but there is no nothing stopping from infectious colitis from becoming also diffuse, right? So just remember that it can infectious colitis can also be diffuse, yes. But yes, Crohn's disease, unless if it is a fulminant Crohn's disease, it's not going to be diffuse, or it can be complicated by super added viral infections, or in an immunocompromised patient, the Crohn's disease can become more diffuse than being a focal. So just remember that the patchiness and the focality of the inflammation or the diffuse pattern, it's not really, it cannot differentiate between all of them, but yes, it will add a lot of weight. And the same for the patchy and focal inflammation. And this sometimes comes as a lot of surprise for a lot of the juniors, that yes, ulcerative colitis can be a patchy and focal inflammation، بس في الحالة ديت لازم we have to apply كل مفاتيح اللعبة. يعني ما ينفعش مجرد عشان خاطر it is patchy or focal disease يبقى أقول it cannot be ulcerative colitis. No, you can see that sometimes it can be, yes, so sometimes it can be. And then active cryptitis, you see, this is the most unreliable features ever, right? The active cryptitis, because you can see that it doesn't help a lot at all to differentiate between the three. ولو كان أي حد قال يقول لا، ما هو أنت لو جالك a lot of acute cryptitis يبقى to favor infectious colitis أكتر من ulcerative colitis. يعني ايه اكتر؟ يعني مثلا شفت 1 2 زياده، فبالتالي it goes with the infectious colitis. طب جبته منين الكلام ده؟ اتعلمته فين؟ او ليه؟ او هل مثلا هي بالويم؟ It doesn't work that way, right? So this form of table has been produced after a very big studies, and I guided you before لل British gastroenterology group والguidelines اللي هم حطوها في الreports, and you can في way how we should write a report, and you should be able to use these guidelines with ease إن شاء الله بعد المحاضرات دي. في حين إن mucosal remodeling والirregularities اللي هي بتحصل في الميوكوزا والسيرفيس والكيرف distortions والكلام دوت، which we can put it under the mucosal remodeling. Some people love these things. You can see that it's more with the chronic, with the Crohn's and ulcerative colitis. لكن there are some types of infections. يعني مثلا salmonella. يعني أنا مثلا بشتغل let's say ان انا بشتغل مثلا في العباسيه، اوكي، في عين شمس، في العباسيه، في الدمرداش، اوكي. فكل يوم وانا مروح بعدي على عم زكي بتاع الكباب والكفته وباخد منه الاكل لان انا ما عنديش وقت اطبخ في البيت، فهعمل ايه؟ اوكي. فالمهم يعني فانا عندي سالمونيلا، فكل يوم بعدي عليه بعد الظهر بيجي لي سالمونيلا تاني، اوكي. اتس اوكي لان انت ما غيرتيش الصوص، هو نفس الصوص بتاع السالمونيلا موجود لسه. فبالتالي الانفكشنز can turn chronic, and the problem when the infection turns chronic it can mimic, of course, as you all know, inflammatory bowel disease. لكن it doesn't happen with all infections. Right? So it does not happen with all infections. And of course, you have to apply a lot of other rules. The other thing is about the neutrophils. And yes, the neutrophils play more important role for the infectious colitis. بس أنا لسه كنت بكلمكم على active cryptitis. بس this is the things that I want you now from today and in the future to divide the neutrophils into two parts. Yes, there is a neutrophils which will cause the acute cryptitis and crypt abscess, okay, which is not going to help you a lot. It just tells you that there is activity in the disease. Either it will happen in infectious colitis and it will tell you بالنسبة للCrohn's والulcerative colitis that there is a disease activity going on. لكن if we start to see a lot of neutrophils in the lamina propria, then just pay a little bit attention to the fact that this may be actually an infectious colitis rather than a UC or Crohn's disease. لأن you can see it, and I will show you how you can see it, but it is not going to be the dominant populations. You see, it is not going to be the easy cells that you will see straight away into the equation. فبالتالي you have to differentiate between neutrophils that are present in crypts or neutrophils present in the lamina propria, because there is completely different way. كل واحدة ليها وزن بالنسبة للdiagnosis تبعنا. I hope that so far the story is clear. Yes, it is not straightforward, but there is two things here I will take from this table: the basal plasmacytosis and the neutrophils in the lamina propria. We need to focus a little bit on those. Then you can see they are completely the opposite for each other. Yes, they are like the patchy and the focal in a way. Yes, because a lot of people love the patchy and focal story. Like now you can see the story of plasmacytosis and neutrophils. They work in an opposite way to each other, right? So they will work in an opposite way. So this is in the way of diagnosis. But here also عشان خاطر الناس اللي هي بتحب تعترض دائما وتقول لك لا انا شفت بليزال بلازماسايتوزيس في مليون حاله كرونز قبل كده. هو انا عارف انك انت شفتيهم قبل كده في حالات كرونز، بس هو للاسف ان كل الحالات اللي شخصتيها كرونز كانت هي يو سي. اوكي، فما علينا ما علينا، دي مش مشكلتي انا بقى يعني. اوكي، بس خلينا في عشان انا برضو بسمع الاعتراضات اللي هي العزف المنفرد. فخلينا مهم روجر فيكنز في البيبرز بتاعته، هو طبعا باثولوجيست مشهور ان هو بيشتغل في وير فري وكاتب شابترز كتيره في كتب، وهو اللي كاتب الجايد لاينز وكده. روجر فيكنز ديت الجمله ديت هو قالها في احد البيبرز او في الكتاب الموست recent book which he published. He said the feature that most reliably, and be careful with the word most reliably, okay? These are not diagnostic, right? These are not diagnostic. they just carries a little bit of more weight. and احنا زي ما قلت لكم قبل كده في الانجليز احنا بنحب نلعب بالالفاظ، يعني بنحب نعوم المراكب السايره، نخلي المواضيع كلها عايمه كده، فهي this is what we do, you see, and this is, you see, it's most reliably. بس it carries some weight for IBD. basal plasmacytosis of course رقم واحد, and abnormal architecture رقم, and crypt distortion and crypt atrophy, irregular mucosa surface, all of those comes under abnormal architecture for me as a or crypt distortion together. I use the word abnormal architecture and crypt distortion together. And sometimes I told you some people might use the crypt atrophy in a different context, like as a whole, if you see it in IBD, yes, I tend to comment on crypt atrophy separate. Like, and it's still, some people might consider it as crypt architectural distortion, some people might not consider it as crypt architectural distortion. Like in basal plasmacytosis as a rule, and it's a problem, isn't it? Because it is the concept of especially the people who like numbers. They say, oh, you have to see a cluster of 7 or 8 cells at the base of the crypt in order to consider it basal plasmacytosis. طيب اوكي، انا خليني يعني امشي معاكم في النقطه ديت، بس هسالكم سؤال الاول. اوكي، this is point A and this is point B. Where do we see the basal plasmacytosis? Is it in A or in B? Okay, so please, you can answer on the chat room now and tell me, where do you see the basal plasmacytosis? So we're getting B, we're getting, some of you said A and B, some of you saying A. Yes, okay. So you can see that I am right, that some people think that the basal plasmacytosis has to be only seen at B. Yes, and some of you said no, only at A, but in actual fact, you should anywhere which is the stand from the lower 1/3 of the crypt, the lower 1/3 of the crypt, and at the base of the crypt as well. So all of this area, if you start to see the sheets of plasma cells in it, then it is a basal plasmacytosis. Okay, لكن النقطة الثانية اللي هي أحب أذكرها برضو على البيزال plasmacytosis, that they can be spillover for plasma cells sometimes من ال upper 2/3 لل lower 1/3, right? So unless if you see it in sheets and or close aggregates, يعني مثلا هنا مثلا أجي مثلا على الحتة ديت, you can count that all of the cells are plasma cells here. Yes, all of them, right? With the lymphocytes, they are not as many as the plasma cells. So that also tells you that you have a basal plasmacytosis, and it's clustering together, and they are trying to dominate the field. They are trying to take over the field. Of course, we have some eosinophils here, and I will tell you also the significance of those in a minute. But I just wanted you to understand that for me, really, the numbers don't matter, providing that I see too many. But because if يعني احنا نرجع تاني لقصة المشهد اللي أنا بحب أستخدمه دايما، وهو مشهد البخيل. أوكي، اللي هو كل ما يعني هو البخيل مش معناه إن هو يعني جاب لك هدية يبقى هو مش بخيل، لا هو لسه بخيل، لأن هو لو أخدتيه وخرجتي بيه مش هيختار الحاجة الكويسة. لو خرجتيه عشان يشتري جزمة هيطلع القطط الباستا فيها عشان ما يدفعش. لو خدتيه عشان خاطر السوبر ماركت هتخرجوا ومعاكوا كيسين عيش وازازه لبن. فهو ده البخيل، مش معناها ان هو اشترى ازازه اللبن يبقى هو مش بخيل، لا هو لسه بخيل. فهي فهي النقطه وما فيها ان you have to have it as a feature. Basal plasmacytosis must be present as a feature. You see, so that is the things in order to call it. It doesn't matter that if you saw it once across one crypt alone, it doesn't mean that this is a basal plasmacytosis. It just, you can say focally, I saw some clusters of plasma cells in the lower 1/3, but cumulatively, when you look into all the biopsies, if it is not there everywhere, or enough, you see enough of it, okay, then you shouldn't consider it as a basal plasmacytosis, because basal plasmacytosis, it is a feature that you saw too many of it in order to label your biopsy as having this. So I think this is clear and good. The other things, of course, now you know that the cryptitis and cryptabscess. يعني أنا لما أجي مثلا أقول لحضرتك دلوقتي, what you can see that the lamina propria, you're trying to hunt for a polymorph, while you saw the cryptabscess very well, and you can see even a little bit of cryptitis, maybe here. Like, what I'm trying to say, that okay, the cells in the background, they are not paying a lot of respect for the neutrophil, like as the crypt have paid the respect. And this goes down to this theory that I have just shown to you in the table, right? So that theory of the fact that now it is reality because you can see it in front of your eyes. Where are they? Okay, why are they like here maybe حوالي 200 أو 300 لو عديناهم سوا جوه الكريبت؟ فين هم دول ال 200 و 300؟ يعني انت جاي سعادتك بتتحامى يعني في الكريبت وسايب لي اللامينا بروبريا مغاغه. it doesn't function. It's not working. Is that clear? Is that clear in everyone's mind now? Yes, you can see that, right? Please tell me that this is clear. Okay, good. Right, no one is answering, so that means not clear. Okay, right. You can see that in the background, you can actually see a lot of lymphocytes, plasma cells, maybe histiocytes. Like there is a lot of plasma cells there, right? And you always have to ask yourself why I'm getting something like that. You see, so that's one other thing. And then I tend to when I look at the inflammation, especially if all the biopsies are orientated that way, then it becomes hideous, right? It becomes very difficult to be able to comment on the inflammatory pattern. And a lot of us, including myself, might think that okay, there is marked increase in inflammation here. Okay, it looks very blue, this biopsy, but you can see the crypts in general, they don't strike you. They are very textbook-like, yes, like very even. They are all like donuts مترتبين زي البقلاوة عند قويدة، نفس الترتيب ونفس السايز، ومفيش أي حاجة تقول إن في هنا أي disturbance. Because I feel that there is two reasons of this over interpretation. Sometimes it takes place because we tend to ignore what we call it the inflammatory gradients, right? That the center of the biopsy is pale, while the periphery of the biopsy is darker. And these inflammatory gradients, it does tell you that you most likely don't have a significant increase in the lymphoplasmacytic infiltrate, لأن lymphoplasmacytic infiltrate, when it is increased, it tends to give you the appearance of loss of gradients. Yes, so you will lose that gradient. So the center will be as dark as the periphery, and sometimes even the center will be darker than the periphery, right? So I want you to pay a lot of attention to the gradients, right? Because if you see that the inflammatory gradient is preserved, then you are overcalling. وبعدين النقطة الثانية برضو اللي أنا أحب أذكرها لحضراتكم هي that a lot of people say there is chronic inflammation present in the lamina propria. Yes, a lot of people use بعفويا وبمنتهى حسن النية يستخدموا this sentence: there is increase in there is a chronic inflammation present in the lamina propria. However, the true story is that the lamina propria, as you all know, it's already an inflamed lamina propria, even under normal condition. So when you tell me there is a chronic inflammation present, this is completely and utterly wrong sentence to put in any GI report. وهو يعني أنا لو if I am going to review a case and I see that this is saying there is chronic inflammation in the lamina propria في microscopic description, it gives me an image of what type of pathologist this is. Yes, because what you need to say, there is increase in lymphoplasmacytic infiltrate in the lamina propria with loss of gradients. Yes, this is how you should phrase the sentence, right? But don't tell me there is a chronic inflammation. No, there is always a chronic inflammatory cells in the lamina propria, but what you are meaning to say, there is an increase in lymphoplasmacytic infiltrate with loss of the inflammatory gradient that's naturally present. Yes, so then I know what you mean, and everyone will read your report, they will know exactly what you mean. So you can say lamina propria expansions, but not with chronic inflammatory cells. You need to specify to me, right? Because lamina propria can be expanded by lymphocytic infiltrate, it can be expanded by lymphoplasmacytic, it can be expanded by admixed acute and chronic, or it can be expanded by eosinophilic rich. So you need to keep telling me all of those. Here it is like another picture, isn't it? Beautiful picture to show you a very good comparison for the gradient. You see, in a biopsy, so I will repeat this again for those who are asking me to repeat. In the biopsy, which is oriented that way, it is more difficult to see the gradients because you don't see the vertical alignment. You don't tend to see where the base is, but the base usually will be in the center of this biopsy, and you can see that the subepithelial part of the biopsy is dark, and here it becomes a little bit lighter. You can see that this area, which I'm marking now, it looks lighter in comparison to the periphery. And if you compare the periphery now to the center, then that will tell you that there is a gradient. And the fact that you have a gradient, that to a great extent telling you that you most likely don't have an increase or significant increase in the lymphoplasmacytic infiltrate in the lamina propria. So this is basically what it does tell you as the gradients. And as I took you to this biopsy now, yes, we can kind of like see a little bit of what might be a cryptolytic granuloma here, right? Which I just highlighted on the right side of the slide. Forget about this. But what I'm trying to tell you that here, it is more or less the same orientation of the biopsy, but you can see that there is no gradients now, right? that gradient is not there anymore, and therefore you have an increase in lymphoplasmacytic infiltrate, and therefore I say there is a significant increase in lymphoplasmacytic infiltrate in the lamina propria. And I wouldn't say expansion. I will only use the word expanded lamina propria with inflammation if they started to space out the crypts, right? But if they are present and you can feel that, okay, or more or less the crypt density is okay, وقريبين من بعض, they are not separated, في طبعا focally separated, لكن in majority are not, and therefore I wouldn't try to jump to the word expansion, but I will only use the word of here there is a significant increase, and then we are happy with that. And of course we cannot comment anymore on anything like that. Here another beautiful cut for the things, but why this is better than now that we can see now that this is very well organized, there is very well spaced out, it's very light. The difference sometimes when you get a cut like this and you're struggling with the inflammatory cell, as it increased or not, just ask them to get an extra level and ask them to cut it at extra thin, right? So sometimes it is easier in a difficult cases, if you're struggling to know if there is definite increase in inflammation or not, to just ask them for an additional levels with ultra thin slices in the lab. So go to your biomedical scientist and tell her, how if you adjust it on 5 micron, just can you give me a cut on 3 micron for this biopsy, because it will help you to see a monolayer of cells, and then you will be able to judge the gradients better. So this is another area that I did find people struggle with. Okay, and here, for example, I just wanted you to your judgment, and I will ask you a question. Tell me if this is infectious colitis, if this is Crohn's disease, or if this is infectious ulcerative or Crohn's. Okay, this is the choices, right? So let me, so I have put 3 choices for you now to apply to me and tell me which one do you think this is. And it's a difficult case. Yes, so this is a difficult case. So we are getting some people saying infectious colitis. Okay, but before we talk about the infectious colitis, do you think there is a crypt architectural distortion here? Yes or no? Right? So what do you think? So there is a crypt architectural distortion. Yes, so that absolutely. So there is a crypt architectural distortion, and there is a foci of inflammation, which is kind of like linked somehow to the crypt, you see. يعني أنا عايز أوضح برضه النقطة ديت. Yes, there is inflammatory cells in the lamina propria, but they are not everywhere, right? They are very close to the crypt. Look, مستنيين بس ياخدوا دورهم عشان داخلين كلنا. داخلين، بص كلنا داخلين، ما تقلقوش. هو بس لو نقف وناخد وقتنا وناخد الدور، اوكي؟ لكن هنا ما فيش. Look at this, right? You see, this is a close proximity of neutrophils to the crypt. Still, somehow it is very linked to the crypt, right? And where the other cells? فين أصحابنا وحبايبنا الليمفوسايتس والبلازما سيلز وكل الحبايب والأصحاب اللي هم بييجوا ينورونا كل يوم؟ هم فين؟ اللي هم بتوع الانفلاماتري باول ديسيز دول. مش موجودين. لا موجودين، لا مش موجودين. اوكي اهو. فين اللي شايف plasma cells يرفع ايده. This is what it is. Okay, اللي شايف في واحدة. I can see one, but this is what it is. Okay, so you can see where is your polymorph, right? Where is your polymorph and where is your lymphocytes? You see, so this is another story that you have to be very, very clear of. That I give you, yes, 3 choices, but there are more sides to the equations, because yes, it can be a drug, because the focal active colitis, as you know, it can be drug, but what else can it be? You see, do you know what is one of the very common active chronic colitis, focal active colitis? The focal active colitis. Let's before I go to the focal active chronic, but I just want you to tell me about the focal active. Do you know what is the commonest disease that produce the focal active colitis? I'm sure a lot of you came across focal active colitis. I want the diagnosis, the clinical diagnosis, the clinical diagnosis to produce a focal active colitis. What is it? Okay, what is the clinical diagnosis, not the pathological diagnosis? Your pathological diagnosis is focal active colitis, right? So tell me, where do you see focal active colitis, in which diseases? Okay, so we see it with drugs, yes. So I took the drugs off the table to make the story more difficult, right? Yes, you can see focal active colitis in inflammation, traveler diarrheas and things. People who travel, you can see focal active colitis. Yes, so infectious causes, yes. Okay, right, what else? You see, the commonest, what is the commonest diagnosis في مصر وفي العراق وفي العالم العربي? What is the commonest diagnosis? Tell me. The commonest diagnosis by a family doctor, by the clinicians, بعد دكتور البطنة ودكتور الحوادث ودكتور الحلقحوش ودكتور الفيتامينات ودكتور كله. What is the commonest diagnosis? Irritable bowel disease. القولون العصبي. That is the commonest diagnosis, isn't it? The commonest clinical diagnosis لأي symptomatic patients with bowel disease is focal is قولون عصبي or irritable bowel disease. And when people did studies around the irritable bowel disease, what they found out that there is a significant proportion of these patients do have focal active colitis. either بقى هم بيجي لهم focal active colitis عشان خاطر عمالين يبلبعوا مسكنات عشان خاطر تهدي الموضوع وتعرف تخرج وتعرف تتفسح وتعرف تتبسط، ديت موضوع آخر. Okay, this will need a more complex study. لكن just based on a lot of studies, they say that irritable bowel disease actually can have focal active colitis. لكن نرجع للحالة بتاعتنا ان هو you can see that yes, we don't have a lot of inflammatory cells in this, and but you have the focality, and so this is again, if I take you here, it might be, you see, this might be, and it depends on the history now, right? So this can be introduced by a chronic drug injury, right? So something like that, which will give you some architectural distortion and some focal active colitis. So you can get that, but you cannot call it focal active colitis because you have crypt distortion now. So you cannot let the crypt distortion go because there is a crypt dilatation for sure, and that's quite deep. That's not surface crypt dilatation. So we are worried. But the drugs, so the drugs can introduce this, but sometimes you can see a picture like this with depletion of the inflammatory cell infiltrate in quiescent colitis with very, very focal disease activity. You can see something like that, but you tend to see more chronic inflammation admixed with active inflammation in general. So to be honest, prolonged drug injury or drug-induced injury can produce similar features to this. And don't sometimes I might do immuno to exclude, of course, any nasty signet rings in when I see something like this, or but not quite often. But if I see a lot of these foamy macrophages, I worry, and I tend to try to pay some attention to it. Okay, and then I tend to then I'm taking you through a lot of cases just to highlight the principles of what we are discussing. And yes, in the eosinophils are not important in the drug-induced injury in the colon. So it doesn't work that way. There is a difference between drug allergy and the direct drug toxicity to the bowel. This is not a drug allergy. This is just the chemicals of the drug will produce a direct hit and direct injury. So do not mix it with the other causes of eosinophilic colitis. Eosinophilic colitis is a different story. That doesn't indicate that's a drug allergy, food allergy, especially when you see it in children. But the active colitis and the drug-induced colitis is a completely different story, and it's related to certain drug that we know in certain patients it will produce this type of injury. Dr. Ghada, I hope it is clear that differentiation between the two. So the basics, as we know, and I just wanted to prove the point that the plasma cells will stop in the upper 2/3, but you might get some spillage of plasma cells. Like here, there is a cluster of 4 trying very hard to go a little bit lower, but this is, to me, is not enough. This is not enough. I am not going to call this basal plasmacytosis, right? First, in actual fact, it is not only about the count, and this is where people go wrong. It's about the entire things. Okay, let me ask you a simple question. If there is an increase in lymphoplasmacytic infiltrate in the entire biopsy here, yes or no? Right? So is there an increase? Yes or no? Tell me. Okay, then the fact is that some of you started to imagine that there is a basal plasmacytosis. انت حكمتي على القضيه اساسا بالفشل من قبل حتى ما تاخدش الجلسه الاولى يعني. فليه؟ لان why did you judge the basal plasmacytosis in the absence of increase in lymphoplasmacytic infiltrate؟ ما هي البلازما سيلز لازم تبقى increased الاول فوق وفي الدور الثاني قبل ما تنزل على الدور الثالث. اوكي، ما هو الماسوره لازم تضرب فوق الاول قبل ما تخش علينا، مش كده ولا ايه؟ اوكي right. So it is not only the clustering. Yes, the clustering is important. Yes, people will go for 6 or 7 cells standing together. Number 7 or 8 is the real number, really, if you wanted to go by numbers. But you have to judge it first. You have to judge the lymphoplasmacytic infiltrate first, and then you will be able to judge the entire story after as a basal plasmacytosis, yes or no. So just remember, it doesn't, this spillage of plasma cells that you might see it in between some crypts in the lower 1/3, it's not necessarily carries significance unless if you see it in the background of a significant increase of lymphoplasmacytic infiltrate. Okay, here there is now, if this is consistent, can you see the number of plasma cells? حفلة 20 30. Okay, this is a different case. By the way, all of these are different cases. So you can even see here بداية Pannis cell metaplasia. You can see that in the background as well. Here, these are new endocrine, but here you can see Pannis cell metaplasia, which is people love and adore for ulcerative colitis. But what it is that this is different now. You can see, yes, there are a lot of them in between the crypts, like here and there, but there is a lot of them also at the base of the crypts. And but not necessary that you will see it under every crypt, but if you start to see a lot of them around your biopsy, then yes, by all means, this is the basal plasmacytosis. And as you can see, you don't really need to count, right? People who are minded about counting things are very short-sighted. It's about the density, about how many do you see around, is it around all of your biopsy to call it as a significant findings, yes or no? If you put all of those together, then you consider the basal plasmacytosis. Why I'm going around the basal plasmacytosis a lot? Because from the table, which I showed you a few minutes ago, basal plasmacytosis is very important because it's very linked to your UC. It carries huge weight, right? Huge weight. You can actually put hand on heart sometimes and say, I know that this has to be UC. And then even if the clinician is telling you, no, that's not classic. Yes, it's not classic in terms of features, but what we see is a very pathognomonic features here that carries a lot of weight. And unless if you convince me that there is something else, then I will take that off the chart. But just remember this story, and remember how we assess the entire situation. The other thing is that people sometimes mention in the in textbooks and in papers and in meetings as well, where do you find the acute inflammatory cell infiltrate, right? I am not sure if I would use this, but I will mention it, and you might find it written in books, right? But what I am trying to highlight here, that in okay, let's apply the first rule. The acute inflammatory cells, more or less, I can see more of it in the crypts rather than more of it in the surrounding lamina propria, right? Some of them kind of like showing the gradients where the cells are a little bit lighter, but it's very faded in some other areas where we cannot see any gradients at all. So sometimes, yes, you in the focal activity in Crohn's and in focal active colitis, you might need to judge the gradients focally, right? So this is one of the things that you may wanted to learn and teach yourself. How can I assess the gradients focally, right? So between the crypts, because usually the focality of Crohn's and focal active, they sit in between the healthy crypts and between the healthy lamina propria as well. بس القصة اللي أنا برضو عايز أشرحها وأقولها لحضراتكم هو إن في ناس يعني كلهم أفاضل طبعا وعلمونا ولسه نزال بنتعلم منهم, and they have a point. هم بيقولوا إيه؟ بيقولوا إن لو كان الانفلاميشن أكتر في ال upper half of your slide, we are talking about the acute inflammation, بما فيها الacute cryptitis, يعني بما معناه إن السيرفيس epithelium اتضرب والكريبت مضروب more في ال upper half, like what I am drawing now, right? Then you may want to think more of a drug-induced injury and infectious causes, right? في حين إن لما يكون الانفection more towards the lower half of the crypt, it might go more with the inflammatory bowel disease or Crohn's disease or things like this, right? So this is the theory. So the theory, again, that you will get a lot of acute, we are talking about the acute inflammatory cells, the polymorph, yes? If the inflammatory cells are targeting the surface and the upper half or the upper 2/3 of the crypts more, we are talking about ratio here, right? Then the lower half, then you will be talking more of drugs and more of infectious causes. بس لو lower half, you will just consider the inflammatory bowel disease because it might be related to this. It hasn't been studied, this theory, yes, but it makes sense. You see, in a drug induce a direct injury to the surface, and therefore the injury will be there. The bacteria, I'm sure the bacteria also will prefer to live in the surface, and we can see the amoeba, we can see the Colistridia, we can see all of these bugs. They tend to sit on the surface more. So why the bacteria will not do the same? So the bacteria will also try to flare up the infection a little bit more towards the surface. So, and here just to show you that theory of no lymphocytes, no or very little polymorph in the lamina propria, and more in the crypts. يعني يمكن حوالي 30 واحد قاعدين جوه الكريبت وسايبين كل الفسحايه اللي موجوده بره من خناقه. اوكي، ما علينا. فالمهم برضه ديت tells you, yes, in the grand scheme of things, this might be actually a Crohn's case, you see, because it's a very focal inflammation. It's in the lower half. I can see the inflammation is more lymphoplasmacytic. So all of this goes more with the story of Crohn's disease, but you can see that there isn't really the clustering of plasma cells. The basal plasmacytosis is not a feature of Crohn's, you see. فما تخليش حد يضحك عليكي ويقول لك لا البيزا بلازما سيلز فيتشر من الكرونز. لا، خلاص اتفقنا على كده. It is not. Okay. I showed you here how Crohn's case, focal activity, lymphoplasmacytic, no lymphocytes in the lamina propria or very little, but there is no plasma cell sheets or clusters for basal plasmacytosis, not really a prominent feature here, right? So it's not a feature. You can get spillage, but it's not a feature. They are still trying to stay apart. They are not forming these little sheets as we consider. This is another interesting one. This is another interesting one. What it is showing, it's showing a feature that it has got a lot of these things. What are these things that you can see inside that crypt? And I want you to forgive me that I don't have diagnosis for this case, by the way. I only look at the cases with you, by the way. So I don't have a diagnosis. I just go through the case with you to show a certain concept. No, I want you to tell me what you can see inside the crypt, which I've just highlighted. So don't tell me about the basal plasmacytosis here. Okay, cryptitis. So, okay, cryptitis. Okay, I agree. What else do you see? Right? What else? What else? Do you see a lot of apoptotic activity? Yes, there's a lot of apoptosis, like apoptosis which we see في الجايني. دكتور علي الله يفتح عليك. You're absolutely correct. And when you see a lot of apoptosis in crypts, just think of drugs as well. Yes, so think of drugs, because the drugs can also be a great mimic. Now, the problem is that you can have combined features. So you can have an inflammatory bowel disease, and you can have basal plasmacytosis, but apoptosis can happen. You can have cryptitis, but what it is, the feature, if I am to pick up, there is a lot of features here you are able to see in front of you, but if I am to pick up one feature that I wanted you to focus on, again, going back to the fact that the basal plasmacytosis carries a lot of weight, but you have to be 100% certain that you can see it. You can definitely see it in the lower 1/3. You can see them sheeting. These are not clustering anymore. This is like a sheet of plasma cells. Okay, so that will carry a lot of weight into the equation. Yes, if you see a lot of apoptosis, you can say can you just make sure as well that there is no combined features of some drugs? As you know, these people get hit with a lot of immune modulation. And guess what? One of the most common drug to produce a focal activity or focal active colitis is the immune modulator, which you will be using them for UC. You see? So it is part of the equation that yes, if you see a lot of apoptosis in a UC case, just tell them what they might need to do in a case like this to change the immune modulator to shift to a second line or a different drug by a different company or something like that, because it appears to be that there is a combined feature of drug injury that's happening also with a background of chronic UC, which they don't work together, but they can if the drug itself that you're using to treat the UC is complicating the picture. Yes, the drug is good. It is controlled the disease a little bit, but the question that sometimes the clinicians send to you, when should we reduce the dose, right? This is what they wanted to know, because the patient really with immune suppressions and immune modulators, very tired and exhausted. I don't know if you know anybody on these drugs, but they tend to be malfunctioning in a good time for the week. Here is the close up again to highlight for you the present, but you can see that yes, the plasma cells are taking over a little bit the lymphocytes, but so there is definite increase. But in the upper part or in the higher up, you can see that there are more lymphocytes, but as you go lower down, lymphocytes they become less, plasma cells are a little bit more, and this is like a reverse gradient. So the R sheets, yes, and then you can confidently tell me that there is a basal plasmacytosis. And again, I wanted you, and I will leave you with these slides because we are nearly over time now and you have a lot of things to do. But the second step to think of is why in a case like this, you are getting a lot of plasma cells and sheets of them. If this is an infectious colitis, because you might think, okay, it's in the mid zone somehow, okay, so it's in the mid zone, but there are some lymphocyte acute inflammatory cells, but زي ما قلت لكم, they are trying to stay close and nearby to the crypt, still part of the process. If you go a little bit away, like here, you don't see a lot of them near the surface. They are not there. They are targeting the middle of the crypt. More of cryptitis happening toward the lower part, but the cells, the plasma cells are taking over. And if the plasma cells are taking over, then you cannot call this infectious colitis unless لو انت بتعدي على راجل بتاع الكباب كل يوم بالسالمونيلا وكل يوم تاخدي الجرعه تمام الصبح قبل او بعد الظهر بعد الشغل. If this story is not your story and your story is more towards UC, then you will have to think more of this as a UC with activity rather than an infectious colitis. لأن why these sheets of plasma cells are there, why the basal plasmacytosis is there, this cannot be an infectious colitis لكل الأسباب اللي احنا ذكرناها today. And I think we will stop here